Okay, Dr. Manju, please go for it.
Okay. Good evening, everyone. Is the screen visible, sir?
Screen is visible and you're audible.
Okay, thank you, sir. So, good evening, everyone. I am Dr. Manju Beshwas, and today I'm presenting a case for the peer review. And the case I'm presenting is a full-term male baby born by a normal vaginal delivery was admitted with a complaint of severe birth asphyxia, was admitted at birth only, had a multiple seizure episode on the first postnatal day of the life, had got poor perfusion, so was started on inotropic support also. During the stay, it was a prolonged ventilated support till 18th postnatal day. The baby was hypertonic with absent reflexes, was tube feed dependent, and was on multiple anticonvulsant was required for controlling of the seizures. Initially, the cranial ultrasound, first cranial ultrasound on the first week of the life was normal. The second showed one grade 1 PVL, and the repeat cranial ultrasound was done at the 33rd postnatal day. This was the first slide.
Yep.
So, okay, this is the first view. Oh, sorry. Uh, as we can see, it is interhemispheric fissure,
Yep.
and these are orbits, and we can also see multiple cystic lesions all over the frontal areas, also adjacent to the interhemispheric fissure also.
That's correct.
Okay. Um, then in next view, same multiple cystic lesion around the frontal areas and adjacent to the interhemispheric fissure. Also the frontal horns of the lateral ventricle we can see, and this is the clavum septum pellucidum in the middle.
Manjuji, is this a scan on day one?
Uh, it is on 33rd post
33rd.
33rd post natal day. Yeah,
Okay. Okay.
yeah.
Well done.
Baby is
Carry on.
almost yeah. Um, then same here, cystic changes in frontal area adjacent to interhemispheric fissure, clavum septum pellucidum, and lateral ventricles are seen. And the cystic lesions are then got extended into parietal lobe also.
Yep.
And
So very nice images. Carry on. Yep.
okay, okay,
Brilliant.
sir. Then we can see foramen of Monroe, and the third ventricle is started appearing, and same cystic lesion in the frontal lobe, parietal lobe, and some of the temporal lobe is also involved.
Hmm.
Uh,
Yep.
okay, yeah, sorry. Then mild ventricular dilatation along with both bulky choroid plexus, and cystic changes same on
Yep.
the frontal lobe. Um,
Yes. Very good.
okay, sir. This was then sagittal mid sagittal view. Actually, at this time, the baby got scissors, so images were somewhat blurred at this time. So sorry for that.
No, no, not at all. These images are good. See, you're using a linear probe, and it just
Yeah, sir.
highlights
I
that you can get very
I have
nice
only
images.
linear probe, sir. Sorry for that. I
No, no,
don't
no.
have curvilinear probe.
Please don't apologize. These are brilliant images. I mean, I can see very nice subcortical periventricular leukomalacia. It's subcortical leukomalacia as opposed to
Okay,
being
sir. Okay.
completely periventricular. And again,
Yeah.
classically, you just wonder whether did this baby have any evidence of meningitis? Just out of curiosity.
No, sir. Never. CSF
Never.
was totally clear. Yeah.
Okay.
Yeah. He got multiple time ventilated because of aspiration pneumonia. So on and off ventilative support was required, and up till now he's almost having conducted sound all over the chest, and tube feed dependent hazard, and
Yep.
reflexes are poor till now. Okay, so this is mid sagittal view, and this is lateral ventricle, clavum septum pellucidum. Then this is third ventricle,
Correct.
then aqueduct, fourth ventricle, and then
Brilliant.
this is foramen magnum. This is said.
Yeah, cisterna
Okay.
magna. We tend to call it the
Sorry,
cisterna magna. Yeah,
cisternum magna.
yeah,
Okay. Then this is our vermis, cerebellar vermis,
correct.
and this I think pons,
Yep.
and mm, and same sir.
Yeah, you have a
This
lot of subcortical leukomalacia
flat.
there, which kind of
Okay.
suggests that this baby has had very severe insult, 30 days, and he's developed quite significant cystic change. So very severe
Yeah.
insult around that time.
Okay, sir.
Is this your last image?
Okay.
No, you got more images. Carry on, please. Yep,
Yeah. Then towards left I have started. Then these are the parasagittal views.
yep,
So the extensive you had told us के subcortical paraventricular leukomalacias and bulky choroid are there, and
yep.
ventricular dilatation is also there. I don't know what is this.
I think that's just cortical tissue that's there below the periventricular kind of the subcortical leukomalacia is the way I would put it. And you've basically
Okay.
got a cut on the left side of the ventricle with the choroid plexus. So
Okay.
it just shows quite extensive cortical leukomalacia, which kind of
Okay.
indicates that the perforating blood vessels from the cortex are the ones where there was significant ischemia. So it's very uncommon. It's this kind of a presentation is more common with congenital heart disease, but
Okay.
usually you tend to get more of a kind of a watershed again, paraventricular periventricular area involvement. So this is quite uncommon, and one of the areas where you can get this kind of presentation is if you have meningitis, because again the deep
Okay.
perforating vessels less affected. It's the subcortical penetrating vessels that get infected because of exudate. So I mean, it's not a nice scan for the baby, but in terms of your images, brilliant. You're using a linear probe, and actually you're getting the majority of the sagittal view over here with the corpus callosum. Sorry, for some reason today my marker is not working. I can't explain exactly why, but yeah, carry on.
Okay, sir. And this were right-sided views. So you
Oh
can
dear.
see
Yeah,
extensive cystic lesions all over the parietal,
yeah, yeah.
temporal, and occipital also, I think so.
Yeah, this is classical HIE now, middle cerebral artery involvement. So you've had extensive middle cerebral artery hit as well. So my God, it's quite difficult for this baby, and that this is quite severe, extensive, what we call is leukomalacia of virtually the whole of the cortex in the parietal region. And this is the right side.
Yeah, sorry, this is the right side.
Yeah,
Okay. This much was no, sorry.
sure. Let's go back to
Yeah.
your first image. So just to give everyone a flavor of people who will not have a microconvex probe can use the linear probe and get images that will be able to give you the same amount of clinical delineation as long as you clinically correlate. The gain settings are perfect. Actually, what I do feel is there's a lot of frontal blush here. And
Mm.
again, the question from our perspective is maybe just reducing the gain settings a little bit. But in terms of your leukomalacia, this is classically anterior cerebral artery region, and you've got quite extensive subcortical leukomalacia. Now, I suspect that if you had a convex probe and you got the kind of outer parts of the lobes, you'd see that leukomalacia extending. So don't hesitate to move your probe laterally to capture those areas. And you might have to take more than one image because of this. But the images are beautiful. Next image. Again, very similar. You see the orbits, the frontal lobes, very bright areas there with leukomalacia in between ventricles, frontal horns just starting to appear, and then you move backwards. Yeah. Ooh. And actually, you start seeing leukomalacia in the deeper parts of the brains, especially on the left side and the right side. I wish my marker was working today. Let me just see if I can activate it. No, unfortunately, I can't. Carry on. You have superficial and deep leukomalacia here because in just ipsilateral to the ventricles, you can see small cystic areas. Just if you take your arrow, yeah, just further laterally, just yeah, here and below, just yeah, these regions over here starting to break down as well. So I would not be surprised if in due course, if you did another scan, you'd get further breakdown. And this is very much in the region of the basal ganglia and thalamus. So, I mean, survival of this baby will not be without consequences. You know, you've got both superficial and deep areas involved, and this is bilateral involvement. Do you have the left parietal region?
Left, right. This one.
This is midline. Then you've got left lateral on the right hand side. Just do you have
Yeah.
another image going out?
No, sir. I don't. I
No
don't have
problems.
that.
No problems. It's fine. I mean, from an image interpretation perspective, you've got cortical and you have an element of, I'd say, paraventricular locomalacia in the frontal areas. This is the area of the trigone, and I don't see much periventricular locomalacia over here. Again, a high resolution image might be able to pick that up a little bit better. But well done. And yeah, it's unfortunate for the baby. But you got any other scans to share?
No, sir.
Well done. Well done,
Yeah.
Manju. God bless you. That's
Thank you, sir. Thank you very much.
very good.
Manju, sorry, can I ask something
Yeah,
as well?
please, please, please.
Was the echo normal? I saw two babies with very similar presentation, and one preterm and one term. The term also presented with like HIE, and they both had like large intra-aortic clots and with like
Mhm.
devastating PVR, like very similar images.
So, Dr. Manju, did the baby have an echo?
Yeah, he got a echo and nothing was there, man.
Sure, sure.
Yeah.
Well done. I mean, I suspect a cardiac element to the hypoxia ischemia with the severity of HI must have been there, and that often after reperfusion injury contributes again to cerebral necrosis. So, yeah, thank you so much,
Okay. Thank you, sir. Thank you,
Dr.
sir.
Amani. Are you ready to share?
Yes, just 2 seconds and I'll put my screen up.
God bless you. Dr. Amani, you're muted. You'll just have to unmute yourself.
Okay, can you hear me now?
Brilliant.
Yeah, is my screen visible?
It is.
Okay,
You can go to full
um,
screen mode. Can you go to full screen mode?
sure, if I know how to do it. Um, 1 minute.
So it's just that small window at the bottom.
Yeah,
So if you take your arrow down to
yeah,
just get notes, and then if you go to the, yeah, just there, you were just there.
okay,
Not the zoom. No, 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 not the zoom.
okay.
Just next to it, to the left of it, next to the minus sign, there's a screen. Just click on that.
This one, slide,
Yeah,
yeah,
yeah.
sure.
Brilliant.
Okay, yeah, so good evening, everyone. Um, right, so I'm presenting a baby whose mother is a gravida 3 parent 2. She has antiphospholipid syndrome and had previous miscarriages. She was on Clexane, received antenatal steroids. There were no risk factors for sepsis. So this baby was born at 26-week gestation by emergency section for abnormal CTG. There was active resuscitation. Baby was intubated at birth and received surfactant. And then we noted that the baby was bruised, and checking the clotting factors, he had clotting, deranged clotting, so received FFP, vitamin K, and the noticeable thing that baby had bleeding from all orifices, even including the OGT. So we even had to give this baby protamine at the advice of the hematologist. So then that resolved after a few hours, and baby was extubated in 72 hours, remained well. He had several episodes of reintubation because of query sepsis and increased oxygen requirement. The the scan I am going to present is a term scan. So the first cranial ultrasound showed grade 4 IVH. So this is a term scan. You can see the interhemispheric fissure,
Yep.
beginning of the lateral ventricles, and there are a bit of big cysts on the
A-
lateral side.
so they're asymmetrical. That's correct. Yep.
Okay.
And
And
yeah,
this is, yeah,
yeah.
another part where you can see that asymmetrical ventricles, no obvious bleeding. You can see the third ventricle and beginning of the cerebellum. Um,
Yep.
and then again, noted that there might be a bit of cyst on the frontal area here.
Yep. Correct.
Yeah, this is another image. Tried to get the dancing lady here, but wasn't very clear. And again, you can see cyst on the side. They're beginning of a sulci on this side.
Yep.
Then this is a trigon, and I think again there were obvious cysts all over.
Yep. What day of life is this, Dr. Mani?
This would be term plus,
Term plus.
probably about, yes, about 40 plus
40
weeks.
plus weeks.
That's
So
on this
14
chart.
weeks.
Yeah,
So 14
yes,
weeks. Yep. Lovely.
yeah.
Yep.
And this is the midline sagittal view. Again, you can see the cerebellum, the fourth ventricle. Not very clear, the corpus callosum, but
Yep.
again, I think cyst obvious from
Yep.
different places. Yeah.
Yep. Yeah. Yeah. Brilliant.
And this is the right side. Um, I think there are some cysts on this side,
Yep.
apart from this one. And this is the left.
Mm,
Again, a cystic lesion here,
yep.
lesion there.
Basal ganglia is involved. Yep.
Yeah, bit,
Yep.
yeah. And that's again the more of the left side. Same. This is the right. So you can see slightly dilated ventricle, but again, cyst
Yep.
lesions. Yeah.
Yep.
So this is the far right as much as I could go.
Yep.
And again, this is, I think, the right side. Yeah, so that's it.
Brilliant.
So the report was that this baby had cystic lesions on the parietal and the frontal region. We did an MRI scan, which has confirmed this. And actually, on examination before discharge, the general motor assessment, the baby scored very low.
Mm, the GM CSF. Yeah. Can we have a look at your images again? So
Sure.
again, which machine are you using?
GE?
You're using a GE. Okay.
Yeah.
So we're using a
This is,
curvilinear probe. This is the midline. So
yeah.
again, very nice image. Uh, you've got the whole of the brain, and it takes about three-fourths of your screen, which is fantastic, which is good coverage. It means that you're really getting the anatomy really nicely. You can just about start seeing some of the meninges and then basically the cortex, and you've
Mm.
got good sulcal kind of gyral differentiation at the term at this particular point in the midline. Now, do you have time gain compensation on your machine?
We do, but this is one of my first scans, so
Sure.
I wasn't sure how to, yes, manipulate the
Well done.
machine. Yeah,
Well done. I'm
yeah,
sure. So the best thing to do is, so the only reason I mention is what you can see is that the gain in this part of the image is much brighter as
yeah,
compared to the gain in the upper half of the image. And the problem
sure.
is if you turn the gain up as total gain, then what will happen? It'll make this image brighter. And
Mm,
whilst this image will become more bright, you'll just get a lot of gain here. So
mm,
by basically adjusting time gain compensation in the upper half of the image, so time gain compensation will look like this. You'll have basically a vertical array
mm,
arranged in the midline with buttons
okay,
arranged here. So this
sure.
represents the lower half of the screen, and this
Mm,
represents the upper half of the screen. And what you'll need to do is move the gain settings for the upper half of the screen to increase gain and basically reduce gain in the lower half of the screen, and that will basically make the image more uniform. But in terms of interpretation, absolutely no doubt, you know,
mm.
you've got quite extensive leukomalacia. Should we just see your frontal images? Because what you can classically see there is evolving porencephaly.
Yeah, that's one of the, yeah, one of the reports was, yeah, there is involved.
So if we just go to the front, yeah. So really, when you come to this area over here, you can see this large area. Was it a left-sided grade 4?
Yes, yeah.
Yeah. So you've got breakdown that's coming in this area over here. The ventricular margin is quite clear, but this entire area, this lobe, in fact, frontally is quite atrophic. And you
Mm,
just wonder whether this area will break down into one big cyst at some point, which we call a porencephalic cyst.
mm-hmm,
Your image here is beautiful. So this is classically uniform gain throughout, and the back of the brain always appears more bright. So these are perfect gain settings for you at this particular point on your machine.
thank you.
Any questions, anybody? Any other scans to share, Ramani, Dr. Ramani?
Um, Not at the moment,
No
just not well
problems.
organized. Yeah,
No, that's
next
absolutely
time.
fine. Next time,
Yeah,
because we'll have a lot of
right.
peer review now. Uh,
Okay.
Thank you so much
Yeah,
for sharing.
thank
Uh,
you.
Nora, can you hear me?
Yes, yeah, I can hear. Yeah,
Nora, were you going to share
sure.
today?
Yes, yeah. If I
God
can,
bless you.
yeah.
Please, please.
Can you see
I can
the
see the screen and
slide?
you're
Yeah.
audible.
So I'm going to present a case of a 34 plus 0 weaker male baby. The baby was macrosomic. Birth weight and length were above the 97th centile, and the head was between the 90th and the 97th centile. It was an IVF pregnancy. The mother had no GDM, and the baby was delivered by C-section due to abnormal CTG. Because of the good weight, initially it was tried to keep the baby with the mom on the postnatal ward, but around 12 hours of age had some respiratory distress, wasn't feeding well, and had a low blood sugar level. He needed non-invasive respiratory support for a very short period of time, and the clinical course was fairly unexciting. He had like a prolonged feed intolerance and was based on clinical features of vomiting and blood in stool without no other clinical kind of like features of
Sure.
something more serious. He was diagnosed with cow's milk protein intolerance, and he also had dysmorphic features, but the chromosomes were normal. And this was a term-corrected scan. And I used a G machine with curvilinear and linear probes. So on the
Frontal.
coronal views,
Yep.
like you can see that the ventricles are asymmetrical. The left lateral ventricle is a little bit larger than the right. There's an obvious cavum septum pellucidum. And in the kind of like this three view, we can see that the codotomic notches are very echogenic.
Hmm.
Um, in the more kind of like parietal areas, the white matter looked appropriate to me for actual gestational age.
Yep.
and there was like a very minimal difference in the size of the posterior horns of the lateral ventricles. The choroids are visible, and there's also a little bit an increased extra
Axial
cerebral
space. Yeah.
space.
Yeah.
On the sagittal and parasagittal views, like on the sagittal view, there's a tiny 3-point cyst. The corpus callosum is, like, to be subjective, it looks a little bit thin, but
Thin.
complete.
Yeah. I was gonna say it does look thin. Yeah.
You can see the fourth ventricle and the distal and magnum appropriate size. And then on the parasagittal views on the right side, like this area of increased echogenicity in the
Mm.
chordothalamic notch, and there's like a thermostriate vasculopathy,
Yep.
and like this echogenicity
Definitely.
was more obvious on the left side, and
Definitely.
then there are also kind of cystic changes already, and then there's also thermocyte vasculopathy on this side.
Yep.
The cerebellar
Cerebellum.
views were normal, like looked normal to me.
Yep.
And then I used the linear probe, and that, like, with this probe, the increased extra or the interhemispheric fissure was more obvious. And also we can see that the cortical folding is probably not as
Mature as we'd
much
want.
as
Yep.
we would expect it for like
Yep.
38 weeks or so. Then we can also see the vasculopathy, somatocyte vasculopathy, and that was the left side with the increased chordothalamic notches. And the reason why I wanted to bring this scan, because I have seen these, so this baby had no IVH,
Mm.
like the early scans were completely normal, apart from the ventricular asymmetry, which is also normal. But I've seen these sort of changes in the chordothalamic notches in like ex-preterm babies around term corrected age. But until now, like I can remember like a 26-week twin pair who had like very severe chronic lung disease, but they didn't have any IVH, and then they had these changes. And I graded them as IVH in the NNet data, which was incorrect, obviously. So I don't know whether there's any, like we checked for CMV,
Yep.
but
So
is there any
I think that's very important in this baby in particular. I mean, a few things that ring out. First of all, what age is the scan done at?
term correctly, like 38 weeks?
38 weeks.
So
And this was a
34 at
34
birth.
weeker. And when
Yeah,
was the first scan done?
like on day 2, like
And
admission on day 1, and like, yeah, within.
I mean, after day two, did you kind of have a gap? And is this the second scan, or have you had scans in between as
No,
well?
no. They were serious scans, like weekly, and we didn't see any IVG.
So, first of all, beautiful images, absolutely amazing. Nothing for me to kind of optimize here. The one thing I would say is a little bit worrying that you have increased extraaxial space in a term baby, which is a little bit asymmetrical. And this is something to keep an eye out on, because really, if it's asymmetrical, some of these babies may have had a stroke in utero. And
Okay.
sometimes the hemispheric asymmetry persists. And we've recently had a case of that. That being said, there's nothing that kind of fits with a stroke based on the fact that you've been doing serial scans. So it might just be developmental. And in that situation, what should happen is as the baby grows, this should normalize completely. With regards to there's definitely no doubt in my mind that it looks like you have a very small grade 1 in the chordothalamic notch. And it's not unusual sometimes. Like if you go back to your previous images,
Yeah.
so can you see how you're getting it? I mean, this is very obvious. And you're getting it somewhere between the midline and the tangential cut. So, I mean, I doubt very much this would have been missed in your early scans. It might just be a late hemorrhage, but the possibility of a vasculitis. So the mother has any history of autoimmune illness?
No.
Just and she
She had
is
miscarriages, although, so it might not. Yeah, she might have.
because you have thalmostriate vasculopathy and you have what looks like a late IVH. So that might be seen in
Mhm.
conditions where you've got autoimmune vasculitis in the brain. So again, I mean, follow up for this baby would almost certainly be the case. And I mean, for a term baby to have all these
Mhm.
features, are you going to get an MRI?
We were not going to like only further
That's
ultrasounds as outpatient and
that's that's perfectly reasonable.
neurodevelopmental. Yeah,
Yeah, that's
yeah.
perfectly reasonable. We're going to talk a lot about that today because
Mhm.
really, again, even in my unit, I don't think we'd get a kind of an MRI for this situation just yet. We'd continue to follow the baby up. Uh, just one other question. Platelets were okay on this baby.
Yeah, platelets were okay. Yeah.
Lovely, lovely.
Mhm.
I mean, no history of resuscitation and good fetal movements.
Yeah, good fetal movements. Closely followed pregnancy because of the IVF,
Yeah,
and like yeah, clinically was like really like just at the beginning the respiratory distress and the blood sugars,
and the
so like
torch screen is
nothing
negative,
major.
you said.
So the CMV we don't know yet.
We don't know. Okay.
That's
So
pending.
that's,
Yeah.
I think you've done
Mm.
everything. And yeah,
Mm.
neurodevelopmental follow-up would be indicated. It's a little bit late to have an IVH in a term baby.
Mm.
And if you have it after the first week to 10 days of life, yeah, the index of suspicion that there might be something else. Hello?
Yeah, yeah.
You can hear me. Okay, fantastic.
Mm.
Just needs to be there. Yep. But
Mm.
brilliant images, absolutely brilliant images, as is the case with all the images that I've reviewed so far in your log. Absolutely
Thank you.
brilliant. You've been scanning for a long time, Nora. Or maybe
Um,
you're very good. How long have you been scanning for?
I've been scanning for a few years. I haven't been
Yeah,
using the other fontanelles like the posterior, the mastoid, and so on.
yeah.
So
Really good opportunity to build on those skills, but beautiful
mm.
images. God bless you. I'm really
Thank
grateful and
you.
thank you for sharing this case. Uh, Dr. Hassoon, are you in a position to share?
Sorry, Alok, but I don't have the setting now.
Don't worry, don't worry. Absolutely fine. We will crack on with we can get you to present next time. But today is a very interesting kind of a topic. And really, what I would like to do is obviously continue asking you questions in between. Uh, Let me just make sure that I can, because this is coming up on screen too.
Can I ask a question, Dr.
Yep,
Alok?
please, please.
In the last scan which Nora presented,
Yeah.
what were we trying to assess by doing the Doppler?
So
We did
basically,
Doppler
yeah,
in.
when you have striate vasculopathy, often putting the Doppler in that region, if you have blood vessels in that region along with it, then it just establishes more that because you can have normal blood vessels like the middle cerebral artery as well. But if you have a fan-shaped kind of appearance to it, like you saw, then that kind of fits with the diagnosis. That being said, there are grades of striate vasculopathy, which I will go through again. And really, when it's obvious and you have grade 3 and grade 4, you don't need Dopplers. It's very obvious. But if it's
Oh,
mild and it's kind of grade 2, or grade 1, you might want to put Dopplers on it just to check and just make sure that it's not just the middle cerebral artery, in the kind of Sylvian fissure that with its branches that you're seeing, as opposed to proper striate vasculopathy.
and I didn't get like striate vasculopathy. What do you mean by that? Like-
So can I cover it? Can I cover it in the next session?
Yeah, sure. It's fine.
No, no
It's fine.
problems, no problems. Is my screen visible?
Yes,
Yes,
yes.
it is. Yes, it is.
Presentation is visible. Okay. So what we're going to talk about today is we're specifically going to talk about antenatal fetal brain anomalies, but really the session from today, we'll be talking a lot about communication, discussion of these anomalies with the parents, what the approach that different people have, because it can be quite variable based on institution, and really the importance of making sure that whenever we have situations like this, that we have some elements of follow-up and we're referring babies appropriately to the pediatric neurologist, because the pediatric neurologist doesn't really want to see every baby who has had mild ventriculomegaly in utero, which is resolved. On the other hand, what I'd say is that if you kind of don't work up a baby with severe ventriculomegaly properly, you're likely to miss a diagnosis, and it can have significant, I would say, implications for the baby's survival, prognosis, and management. And it becomes increasingly difficult if that is the case, if you're working in a kind of low resource setting where you have to pick and choose which babies need to have an MRI. Really, where you don't have a pediatric neurologist, it can be extremely challenging. I'm going to start a little bit with what we call as fetal ventriculomegaly. This is quite common. And for all of you who work in units where there is a fetal medicine unit, it's quite common for you to have scans which basically pick up an element of ventriculomegaly and really follow it up in the pregnancy. And really, ventriculomegaly for a fetus is defined as enlargement of the lateral cerebral ventricles that you can see. This is the choroid plexus that you can see over here. And really, along with the choroid plexus, you can see these ventricles at this particular point. Now, this could be developmental because we know that the fetus, as it develops, tends to have large ventricles, and it may get better. So it might just be a marker of normal brain development where the ventricles are slightly enlarged and will eventually achieve normalcy based on embryological development. On the other hand, if there is something pathological going on, these ventricles may remain enlarged or continue to increase in size. And based on that, we would then have to kind of make a choice as to what investigations we do and how we counsel the parents. Now, measurement basically in utero for fetal medicine is usually the internal width of the atrium at the level of the lateral ventricles, where you can see the glomus of the choroid plexus. So they tend to measure these widths. And really, from our perspective, if you have a width that's more than 10 millimeters, then that kind of is 2.5 standard deviations above normal in indices that have been developed for the fetus. A lot of work that's been done by not just fetal medicine specialists, but also by obstetricians in the 80s established these dimensions. Now, what is important is that ventriculomegaly is a spectrum. And this is crucial because ventriculomegaly may simply be because you've got tissue atrophy ipsilateral to the ventricle. So there's no support tissue, and that's why the ventricle's enlarged. On the other hand, you might have a problem where you've got obstruction of the system that CSF flows through, and that will give you hydrocephalus. Now, the entire spectrum can present with ventriculomegaly. Hydrocephalus may be one component of it, but not every baby with ventriculomegaly is going to have raised intracranial or intraventricular pressure. So ventriculomegaly may be normal pressure as well. And when we classify it, we know from a kind of fetal medicine perspective that mild tends to be between 10 and 12, moderate 12 to 15, and severe more than 15. Now, can anybody tell me where we've come to these conclusions from? How have we decided that these dimensions should be mild, moderate, and severe? Anybody?
Your voice is breaking, Dr. Alok. We couldn't hear the question, I think.
Okay. Can you hear me now?
Yes, we can now.
Okay. So my question is, you have a classification of mild, moderate, and severe ventriculomegaly. So why have we come to this classification? Any thoughts? Why these dimensions? So basically, the literature shows, and I will show you a lot of literature, which basically reflects that once you cross 12 millimeters, really neurodevelopmental outcomes, if this persists in a baby at birth, then not only is there a higher risk of having neurodevelopmental problems later on, but there is also a higher risk of having other brain anomalies as well as genetic syndromes. So initial classifications talked about just mild and severe, where it used to be 10 to 15 and more than 15. But this classification basically talks about moderate as well. And what we know is that if you just have mild ventriculomegaly of 10 to 12 millimeters, now this is usually from a scan that's done about 18 to 20 weeks, then what would happen is you'd have follow-up scans in the second trimester and the third trimester. And really, a lot of mild ventriculomegaly, where you have 10 to 12 millimeters of kind of dilatation, will go on and resolve, and that's normal variant. It's developmental. Now, if this is the case, then really from our perspective, the institute that I currently practice in, the baby warrants an examination, a full baby check, basically to look for any abnormal signs of neurology, any abnormal neurocutaneous markers, any dysmorphology, anything that would indicate there might be an underlying genetic component. And if all of that is normal, then we do not perform scans for these babies. Theoretically, from our perspective, everything being normal, they go on to have a baby check at 6 weeks. And really, then they will be under care of a pediatrician who will follow them up just like normal general population. So unless they've got any other markers, we don't really investigate them if this is resolved. However, if it is there at birth and it is 10 to 12 millimeters, then really all of these babies will get the same. They'll get examinations. We'll look specifically for markers for a genetic problem or any other congenital problems, but they will all get a cranial ultrasound. And based on the cranial ultrasound and those features, we would then decide on further management. Now, most of the cases of severe ventriculomegaly, other than I would say some of the neuronal migration disorders where you have a smooth brain appearance with dilated ventricles because actually the brain is just not developed. In particular, the cortical areas of the brain are not developed. But the other cases of severe ventriculomegaly, obstructive causes tend to dominate. So a problem at the level of the third ventricle, an intraventricular bleed that took place early during development, problems with certain torch infections. They can cause obstruction of the ventricles at different levels. And this ventriculomegaly then goes on to present with hydrocephalus, as do certain congenital malformations that we'll talk about. In terms of the overall etiology, like I said, it could be a normal variant. What we do know is that for babies who have ventriculomegaly at birth, the incidence of chromosomal problems is much higher. We'll look, but I mean it varies based on population. Again, there is a higher incidence in severe ventriculomegaly. Up to 20% of these babies in one study had actually underlying torch infections, CMV in particular, being a major offender. And then, as I said, you can have congenital problems like aqueductal stenosis, where the ventricular system has kind of been obstructed. Problems with conditions like corpus callosum dysgenesis that we'll talk about, and posterior fossa problems, again, that we'll talk about today. Uh, we will cover cortical developmental disorders, holoprosencephaly and hydranencephaly later on. Now, let's just talk about mild ventriculomegaly. So really 10 to 12 millimeters of dilatation. It's not resolved in utero. So a third trimester scan shows that it's still persisting. The baby has been born. And let's say the baby does not have any problems. Well, it could be bilateral or unilateral. And if it's unilateral, actually mild, then really without any underlying kind of genetic syndromes, any other brain malformations, if you have a normal cranial ultrasound, the prognosis is fantastically good. You know, a significant proportion of these babies, about 75 to 80% of them, will not have any developmental problems and they will behave just like general population. Now, we don't really know what the exact prevalence of mild ventriculomegaly is, and that is because we haven't really done population studies of every baby having a cranial ultrasound scan. We also know that a significant proportion of these babies can, they'll be asymptomatic and they won't have, or it may not have been picked up because there's no antenatal scanning that's been done at birth, or because antenatal scanning may not necessarily have picked it up. It depends really on whether the baby's been referred to the fetal medicine specialist or not. But a rough prevalence is about 0.7%, which is 7 per thousand live births. Uh, in work that's been done by Hanel et al., it's even rarer, 7.9 per 10,000 singleton births. The main thing from our perspective is that if you have bilateral ventriculomegaly, even if it's mild, there is still the risk that you can pick up other brain problems. And it may be the sign of an existing brain anomaly, might be a neuron migration disorder, might be the case that actually the baby has got an underlying genetic problem. But these other extraneural abnormalities outside the brain can also be there, especially if you've had a torch infection that's been mild. CMV can cause other sequelae. Genetic conditions can affect other organs. But really, from our perspective, there is an association with these problems. Now, institutes vary in their approach, and really, for institutes which tend to follow up with fetal medicine alone, mild ventriculomegaly, not every baby is going to have a fetal brain MRI. In our setup, insurance has a major impact on this because parents might not be able to pay for it. But most of the Western countries, if you have any element of ventriculomegaly, all the babies will have a fetal brain MRI. And really, from the perspective of kind of diagnosis, that helps to pick up other structural problems if they're then there. But the advantage then of having it done also means that you can look for genetic problems. You can genetically screen these babies. And we know that whole exome sequence has come up in a big way, is being done. But if you have cortical problems with neuron migration disorders presenting with viral ventriculomegaly, you can actually pick them up much better by doing a fetal brain MRI. The challenge from our perspective is without having all of these facilities and knowing that parents have and may not be able to pay, you might not be able to get a fetal MRI. And the question is, how do you then counsel? So I'm just curious. I'm curious to understand from you, how do you counsel your cases of mild ventriculomegaly persisting in the third trimester? Anybody want to give us? So Maria, how are you counseling your babies of mild ventriculomegaly? And
Yeah, we are usually very reassuring, saying that the vast majority of these babies do well. We usually don't do the MRI if it's a mild, only with a normal head ultrasound. And then we tell the parents that we'll follow up the baby, and if any concern arises, we would investigate with an MRI. Do you think it's a
I think
correct
that's
approach?
perfectly reasonable. That's what we do in our setup as well, in particular where it's very much insurance based. And I mean, again, just to give you a flavor, there is a huge amount of parental anxiety, and there's some parents who might be able to afford it and might want to go for an MRI. So really, we counsel, we reassure. In my experience, don't routinely offer MRIs to these babies. I prefer to follow these babies up unless there is something more obvious on the ultrasound, or if the baby shows any features of dysmorphology, in which case the risks of having underlying other brain abnormalities that might not be picked up by cranial ultrasound are slightly higher. So, but that's a perfectly reasonable approach. Uh, just gonna click on this. The main thing from our perspective is that we do not miss babies who might have mild ventriculomegaly with other problems in the brain and possibly other organ involvement or extraneural involvement or dysmorphology, because these are babies who need more diagnostic workup. And really, from our perspective, just remember when you do an ultrasound is like the iceberg effect in these babies. It may not necessarily pick up some of the intracranial problems with enough sensitivity and specificity to actually be able to diagnose some of the cerebral problems that you see. So again, what I'd say is if he's dysmorphic, if there's other features that make or raise my index of suspicion, then really I would think about making sure that I have done some of these things. And the most important thing is the history, your examination. So what you really want to do is examine the baby. You want to take a very good history of congenital infections. Just remember, some of these babies may have had their scans done in the private sector. You may not have a complete history of the investigations that have been done in the private sector. The parents may well have had investigations done, but you might be coming to your hospital for the first time. So you do really need to make sure that there's no history in the mother, especially if she's not had these investigations, of a possible torch exposure. The one other thing, we know that some babies with fetal neonatal alloimmune thrombocytopenia can have small bleeds in utero. And when they have these small bleeds in utero, they can cause mild ventriculomegaly, especially if it's not severe. And in situations like this, just again, making sure that the platelets on the baby are okay post birth. Uh, Now, again, some of that is taking a history from the mother, looking at her platelet count, if that is the case. Looking for dysmorphology. I'm not saying that you should be doing chromosomes for every baby with mild ventriculomegaly, but I think if you have a baby who's got an absent corpus callosum with ventriculomegaly, who, from our perspective, has hypertaylorism, has got That's three soft features for me for midline defects. Absolutely no doubt that this is the kind of baby where I'd be thinking very careful of getting genetics done, but also, an MRI. And then really the other important aspect is the history of how this is evolving. If this is a ventriculomegaly that's was initially 10, has gone up to about 14, which is moderate, then really from our perspective, there's something going on that we need to investigate further. And even if the cranial ultrasound is normal, I think an MRI in this situation might be warranted. Certain things that might be given away on your ultrasound that might help you. So we're just talking about the brain first. And again, if you see periventricular calcifications, as you can see over here, then the possibility that this might be a torch infection. Some babies can have what we call as small subependymal cysts. Again, that might indicate that this baby's had an in utero bleed, which has caused mild ventriculomegaly. Now, if there are no other features to suggest that this baby has got platelet or clotting problems and the baby's completely well, very similar to the case that Nora showed today, I don't think I'd be doing anything other than following this baby up very, very closely. I might, in this situation, want to just make sure that there are no platelet related problems. But look at the baby as a whole. If you've got a history of liver calcification, ascites, hepatosplenomegaly, and echogenic bowel, then really a torch infection, quite a worry at this particular point of time. So you really want to kind of make sure that you've looked at that. Again, if you have an extensive bleed, hyperechogenicity of the ventricular walls uh, in utero, and this is kind of something you pick up on scan, then really neonatal alloimmune thrombocytopenia is something that's very important. Now, we heard Maria's kind of approach, which I would say is very much, I think the standard of practice globally. And that is because when you look at mild ventriculomegaly in studies, the incidence of chromosomal problems is quite low. So really, if you look at all these studies added up, I mean, the incidence varies from about 2 to a maximum of 28. Now, this 28 is only 7 cases. But if you add all these cases up, the overall incidence is just 2.8%. So it means that you would have to do genetics in about 100 babies to pick up 3 babies. That's, the cost effectiveness of that in a setting where viral metriculomegaly may be associated with no significant other abnormalities and the child might do very well. The anxiety that you're going to give the parents while they're waiting for genetics, thinking about doing other investigations, that's a huge amount to subject both the parents and a baby to. So index of suspicion here again is the key. And if you have other features other than just mild ventriculomegaly within the brain, as we've discussed, as we will look going forwards, then really from your perspective, you might then think of wanting to do genetics. When you look at it, what are the common causes of genetic problems that might be associated with mild to moderate ventriculomegaly? So trisomy 21 is the most common cause. We now know that we're picking up a lot of abnormal results on whole exome sequence, broken areas of chromosomes, and we do not know what that means. And really, again, I'd be very cautious in those situations of counseling and saying that this baby might have an abnormal neurodevelopmental outcome based on the whole exome sequence for genetic patterns that have not been defined in the literature. I think there's almost no doubt in my mind I'd be following that baby up very closely. I might well in the situation where I've got other features, refer the baby to neurology, get an MRI, and have a genetic consultation. But really, if the baby doesn't have any abnormal features, and this is just one isolated kind of situation, I'm not going to organize a microarray or a whole exome sequence for that baby. I'm just going to reassure the parents and follow the baby up in clinic. I would not be surprised in due course if there is work, because a lot of the literature now shows an increased rate of genetic problems when ventriculomegaly is more severe. So we might actually end up having population studies now in children with mild to moderate to severe ventriculomegaly, which will help delineate this a little bit better. But again, just another kind of a slide which two studies which show very low incidences of genetic problems. And really, unless you have another soft marker, dysmorphology, something else on the brain that gives it away, then really not many units are routinely doing chromosomal analysis for the mild cases. And in the mild cases, as has been highlighted, uh, 2/3 of babies are neurodevelopmentally normal. And the remaining babies tend to have just mild neurodevelopmental delay to the point where not much of this is really motor. Uh, some of it is cognitive, some of it is basically related to kind of delay in achieving milestones with regards to speech. So the overall cohort, I mean, in just one study that's been done by Kutuk, shows that the majority of babies will do very well. And then there's a meta-analysis done by Pagani et al., which is part of your library, and it shows that neurodevelopmental delay was present in only 8% of patients with mild to moderate ventriculomegaly. And it's a good sample size of 100 plus babies. So, I would be relatively reassuring for this group of babies. When you look at follow-up for these babies in utero, really, this is a really nice study which has been done by Z et al. And what it basically shows is that mild ventriculomegaly above 10 millimeters, less than 12 millimeters, 85% of them will resolve in the pregnancy. And if they're resolved and the baby has a normal exam, we don't do anything in our institute. As I said, will reassure the parents and they will basically have follow up with a pediatrician. But once this ventriculomegaly is more than 12 in the moderate region, then really from our perspective, the risks of having neurodevelopmental problems goes up from 9 to up to 33%. So just, I'd be a little bit more cautious if you've got isolated ventriculomegaly that's more than 12 millimeters without any other findings. I think at least in our setup, if parents could afford, this is a situation where I do a scan, but almost certainly from my perspective, I'd be thinking about getting an MRI. Now, severe ventriculomegaly, on the other hand, has a very, very, very bad outcome. And that is because the variety of conditions that contribute to it, which include genetic problems, neuronal migration disorders, as well as, I would say, obstructive problems, posterior fossa problems with kind of obstruction of the third ventricle, aqueductal stenosis, mean that accumulation of CSF under pressure causes compression of the cortical mantle, and really that causes damage of the brain in utero. It's something that actually has not been corrected. There's some work that's looked at trying to place in utero VP shunts, but without actually much success, very small numbers. But really, if you look at the prognosis, neurodevelopmental outcomes are quite poor to the point where survival might be affected. And this is just a piece of work that was done by Hannon et al., published in 2012, which shows that about 50% of these babies will have associated other congenital problems. About nearly 9% of these babies will have chromosomal abnormalities. 42% of them will have structural brain problems, and the mortality is about 16%, which is, it's quite reasonable. Absolutely no doubt that where centers can, they will always do a fetal brain MRI in association to looking for other anomalies in the body, especially if there's worry that there might be another underlying genetic situation. And in those situations, really, if you want to do genetics, it's best to be able to do it early, because if you get a genetic problem that really can be uh, kind of counseled for the parents, it gives them a lot in terms of prognostication and postnatal management for the baby. We've recently had, and I've had cases of very severe ventriculomegaly where we've had very rare diagnosis where the prognostic outcome for survival was almost nil, and where death in the first 6 months of life was almost the norm. So in certain countries, comfort care might be the approach that they want to follow. So being able to do the genetics prenatally can really help in that ability to be able to counsel these parents. And I mean, there's just a study that's been done by Gagliot et al., which basically looks at the incidence and survival of babies with ventriculomegaly diagnosed antenatally. And really, survival in severe ventriculomegaly was only 33%, so very high degree of mortality. And I would not be surprised, based on where this study was done, which I suspect is Italy, that there was the opportunity to be able to palliate a lot of these babies after birth based on parental choice. Neurodevelopmental outcomes being normal in cases of severe ventriculomegaly, less than 10%. So, when you talk about prognosis in this particular situation, I think if the parents leave your room thinking they're going to have a completely intact survivor, you probably haven't done your job. And that the parents need to understand that not only is there a risk of very high risk of having an abnormal neurodevelopmental outcome. But really, depending on the severity of the ventriculomegaly, there's a very important concept over here. So I'm just curious, and I want to explore it with all of you. So how definitive would you be if you have a case of severe ventriculomegaly with a genetic syndrome with very high mortality? How definitive would you be about the outcome of the baby when you counsel the parents? Anybody?
I will probably be saying most likely using like very cautious phrases because you can never be 100% certain about the prognosis, but I would say most likely and just quoting things from studies that were done that most of these babies did have a developmental impairment, but you can never be 100% sure.
I think that's brilliant. I think that's where I would say that, you know, it's how the parents look at the glass and, that glass, like if you look at this figure, about 8% of babies with severe ventriculomegaly could still be normal. Now, the parents may want and feel that their baby is one of that 8%. And really, the risk of then being very definitive about your counseling and saying that 100% sure that your baby is going to be affected. He's got severe end of the spectrum. He's going to be deaf, dumb, blind, unable to walk in a wheelchair for the rest of his life without any quality of life. I think you've got to be very cautious because not only in that situation are you making a prediction that is quite destructive, which might be the case, but really you can never be 100% sure. But more importantly, you're taking all hope away from the parents. And really, the mother will have to carry this child for an extended period of time unless laws allow for her to have a termination, which is often quite difficult by the time scanning and kind of genetics have picked these things up. So I think what I'd say is there's an element of keeping it open ended. But if the parents wanted information from me and I had complete cortical mantle that's completely destroyed, what I would be telling them is I would be talking about the severe end of the spectrum and saying that I worry that their baby might be severe end of the spectrum based on what I've read in the literature. Can I be certain about it? No. So you leave them with an element of hope as well. And we'll talk a lot about it in the workshops that go forwards. I'd be very careful about being absolutely definitive, even about the severest of the severe cases. The other reason for that is because in some of these babies, sometimes we are very definitive about prognosis and decide on a palliative care approach, which encourages comfort care. But just be aware, some of these babies will breathe. They will breathe nicely. They will not die. And really, in that situation, it becomes quite challenging for the parents to then accept that alternative reality. So it's important for you to be able to parallel plan. And really, again, what I'd say is even with severe hydrocephalus, I've seen babies go home. I've seen them have palliative shunts, and I've seen parents have quality of life with them based even on their severe conditions. So I think quality of life is a very broad spectrum and a very broad concept, and I'd be cautious about using terminology like that, is my kind of take home message. Now, in terms of postnatal management, when I look at ventriculomegaly, as I've discussed, I'm going to do and take a history, antenatal history. When the baby's born, I'm going to take a history. I'm going to examine the baby for any features that's dysmorphology, any features of neurocutaneous markers, other extraneural presentations, hepatosplenomegaly, so very detailed examination. There may be investigations like blood torch. If he's dysmorphic, I might be thinking of genetics, but I'm almost certainly going to use a bedside ultrasound in cases where the ventriculomegaly persists. There's some centers who will do an ultrasound even if it's resolved. We're not one of those centers. I think if it's mild ventriculomegaly, which is resolved by the second trimester to third trimester, and the baby looks absolutely fine on examination, we would not be doing it. Can I just caution you against basically ventriculomegaly that might be in the range of, say, 12 millimeters, where you're kind of going into the mild to moderate range. So those are babies where even if my history and examination is normal and it's more than 12 millimeters, where I'd be having a very low threshold for getting an MRI done, thinking about the potential for a genetics referral, even if the baby's not dysmorphic, especially if it's bilateral, especially if it's bilateral. But in terms of management, again, if it's resolved completely, at least in our center, we don't do genetics and they don't get routine follow-up. There are some centers who are currently doing work on these cases where they're sending whole exome sequences on all these babies as part of population studies. It's research, it's not established. But really, once you kind of hit the moderate to severe end of the spectrum, you really need to think about getting these investigations done to make sure that you're not missing an underlying kind of problem. A lot of this is governed by what your MRI shows. So it's not unusual for us to get an MRI done first, then talk to the geneticist and kind of discuss what further genetics they would recommend based on the constellation of features, history, examination, and the MRI. Most of the cases of mild to moderate ventriculomegaly will have conservative management and only have surgery if this progresses to hydrocephalus. Again, they'll have follow-up most probably with a pediatric neurologist or a neurosurgeon, depending on it. But for the severe cases, really, you are going to have a lot of liaison with the pediatric neurologist and the pediatric neurosurgeon if it's hydrocephalus. And a significant proportion of these babies, depending on their etiology, may end up with different kinds of surgery. So, any questions about ventriculomegaly before we move on?
Can I ask a question?
Please.
Is there like a correlation between the occipital diameter and the axial width of the posterior horns? Essentially, to compare antenatal MRIs to postnatal cranial ultrasounds?
Yes, there is. There is published work on it, which basically helps classify ventriculomegaly again into mild, moderate, and severe. But experience usually says that when we measure those VIs, we don't normally plot them on charts like we do for hydrocephalus. What we normally do is a good example is in setups where MRI might not be available. I might measure a VI based on that literature, and I know that definitely getting an MRI done where possible. There's work that's been done by Mary Rutherford's group that basically establishes ventriculomegaly indices. I'm happy to share that with you, Nora.
But I mean, because like BI measures the anterior horn and
Yep.
the antenatal MRI measures the posterior horn.
Yep.
So should
And
it be like the thalamo-occipital horn?
so if you're saying, is there correlation between the actual cranial scan and the MRI? No.
Yeah.
It's
Yeah, okay.
yeah, but MRI-based classification of ventriculomegaly does exist. Again, a classification of mild, moderate, severe based on ultrasound, I'd have to have a look at the literature and I can come back to you on that.
Thank you, thank you.
Yeah. Usually what I'd say is that if you measure the ventricles and they're more than 10 millimeters at the level of, say, the lateral ventricles, they're enlarged. And again, what we've got to be very careful about is basically correlating that by gestation as well. So it's not unusual for us in situations, because preterm babies will have enlarged ventricles. So follow-up of those ventricles in preterm babies, because you're not going to get MRIs done immediately, would be of more benefit in that situation. And if I find that they're not achieving the normal maturational kind of decrease in the size of the ventricles as they become more mature, I become more conscious that ventriculomegaly might be a problem. And a really good example is at the moment, uh, we have a baby in our unit who's basically got absence of the cavum septum pellucidum, where the ventricles are very prominent. Now, as a preterm baby, that was expected, but actually for a term baby, this baby has got very prominent ventricles with VIs in the range of about 15. And what is very interesting, a very smooth brain. So there's absolutely no doubt we're going to do a term MRI on that baby. So again, a lot of this, instead of defining dimensions, looks at serial follow-up if the baby's preterm. In term babies, like I said, I'll come back to you about whether there's a classification based on MRI and cranial ultrasound of the actual severity of ventriculomegaly. Any other questions?
Thank you, thank you.
Okay, so what we're going to do is now, see, ventriculomegaly in isolation is what we've spoken about. What we know is that ventriculomegaly may be associated with a large proportion of other neurological things that are picked up on cranial ultrasound. One of them is agenesis of the corpus callosum, but you might also see it with posterior fossa abnormalities. And we're going to cover them very quickly. Now, as we know, kind of, this is a coronal view, midline, and really what you see is basically the tram track kind of that you see of two layers of corpus callosum that are visible just above the layers of the ventricles, and this is normal corpus callosum. But if these corpus callosum is absent, then what you get is basically splayed ventricles with the third ventricle being pulled up, as you see over here. And this is classically called the Viking helmet. Why do we call it the Viking helmet? So if I just draw it out for you, so with my terrible art, sorry, my apologies. So that is the head of the Viking that you see over here. And really, from our perspective, those are kind of horns of the Viking. So this is classically called the Viking. It's also from our perspective, when you look at it, given it's called the inverted teardrop sign. But really, from our perspective, when you talk about parts of the corpus callosum, we know it's made up basically of really five parts. And really, that basically consists of the anterior part, which is called the rostrum, then the genu. You then have the body, and then basically the back is called the splenium. But there's a small area, a bump, which we call the isthmus that you can see. It's seen very nicely over here. So from our perspective, five parts of it. And when you talk about agenesis of the corpus callosum, you can have complete agenesis, as you see over here. It's not visible at all. Or you can have partial agenesis, where the anterior or posterior part of the corpus callosum might be absent. Now, it is by far the largest connective tissue structure in the brain and is responsible for transfer of information between the right and left hemispheres. It usually takes its final shape by about 20 weeks. So normally what happens is whenever technicians do scans, this is a view that they'll always look at because they want to make sure that there's no midline abnormalities, and they will look at the corpus callosum. Now, the whole spectrum of agenesis of the corpus callosum is quite a heterogeneous condition because there are a variety of different reasons why you might have it absent. You might have an infectious cause like torch. It's known to happen with Zika. We know that mothers who consume alcohol, especially in the first trimester, may have a toxic element which causes disruption of the corpus callosum. We then know that genetic factors might be associated with it. A lot of midline defects like acardies, septo-optic dysplasia may be associated with this particular condition. Now, in genetic causes, when you try to make a syndromic diagnosis, there's one study that shows that up to 45% of babies came back with abnormal gene studies. So over 200 genetic syndromes have been associated with some element of corpus callosum dysgenesis, absence, thinning. So really, there is a wide spectrum of why you might have it. But we also know that normal population, the corpus callosum may be absent, and in the absence of any other features, prognostically, a significant proportion of the population may be completely asymptomatic. When I say significant proportion of the population, what I mean to imply is that we don't antenatally scan the whole population. We don't have population studies which show 100% degree of antenatal scanning. So actually, there are people in the general population who might be completely normal, me, for example, who might still have it. So we know that there are people who live with it and actually have no problems. When you classify it, it can be partial, complete. So we know that partial might be the anterior or the posterior parts. A complete would involve the whole of the corpus callosum, but it can be thin, as you can see over here. So this is a very thin corpus callosum. Again, something that we saw today in NORA scan. Thin can be normal. It can be thick as well. And there is really a case series of about 60 odd, which has been reported with thickening again, which raises the possibility of an underlying genetic problem. Or it might be abnormal in its shape. This is the classical shape, rostrum, genu, body, isthmus, and splenium. It may be isolated with no other problems, or it may be complex. And when I say complex, that means that you might have an absent corpus callosum with ventriculomegaly. You might have an absent corpus callosum with colpocephaly. You might have an absent corpus callosum with a posterior fossa abnormality. And really, once it's associated with those kind of abnormalities, the chances that you have an underlying genetic problem go up quite significantly. In terms of the incidence, as I told you, large number of asymptomatic individuals, it's very difficult for us to be absolutely certain. But the California Birth Defect Monitoring Program, I think in the late 80s, if I'm not mistaken, basically gave an instance of 1.4 per 10,000 live births. I think it's much more common than that. The reported prevalence is about 1 is to 5,000. And, amongst patients who have neurodevelopmental problems, the incidence is much higher. It's about 3 per 100. So if you have developmental delay, an MRI picking up absence or dysgenesis of the corpus callosum is much higher. And then we know, as I told you, it may be associated with a variety of other kind of problems like ventriculomegaly, Danty-Walker syndrome. We've talked about the genetic kind of issues. There are some people who insist that really because of the high risk of finding genetic problems, that any absence of the corpus callosum should have a microarray. At least at the moment, that's not our practice. In terms of antenatal scans, you can see this is the normal corpus callosum over here. Normal corpus callosum all the way back, third ventricle. And really, when there's complete absence, as you can see in the midline over here, then really from our perspective, you get this classical Viking helmet appearance with splayed ventricles, the third ventricle pulled up, and an interhemispheric fissure which goes right down to the bottom. You may have a partial element of it. And really, once picked up, I think from our perspective, all of these babies, if you have an antenatal diagnosis, need to have a postnatal head ultrasound scan. And we tend to focus on the mid-sagittal and the mid-coronal planes. And the important thing from our perspective is really looking at it very closely. It's really important that in your midline view, you can demonstrate the whole of the corpus callosum from kind of the rostrum, genu, body, isthmus, and the back, all the way to the anterior commissure anteriorly. Because if you're not able to demonstrate it, there's a chance you might miss it. And really, a good way of doing that, and some people like to do that, is basically putting in the anterior cerebral pericallosal artery. So trace the anterior cerebral and the pericallosal artery, and if you can see it in its entirety with its branches, then the corpus callosum should be completely developed. The kind of appearances that we get, signs that are classically described, the sunburst appearance. So there's no corpus callosum here, and you get these rays of sun or a burst. So this is the sun over here in the center that you can see. Some reason, yeah, better. And basically, you've got this sun ray appearance that you can see over here. So it's called the sunburst appearance. Uh, in this situation, you have no corpus callosum, so you will not get any artery. So when you put Dopplers and you try to find it, you will just get no artery. Depending on how much is absent, you may get portions of the artery. But really, one of the classical descriptions is what is called the teardrop sign. So this teardrop sign or colpocephaly is basically dilatation or bullet-shaped nature of basically the occipital horns of the ventricles. And when it's associated with this, really the norm in this situation, especially if you find this and you find that you've seen your whole corpus callosum, please go back and have a look at it again because partial agenesis is a possibility. And then the classical appearance that we call the Viking's helmet. This is the helmet, the horns. This is the head of the Viking. Really, what happens is the third ventricle moves up and the interhemispheric fissure attaches to it. It's also basically called a batwing appearance. So these are the wings that you see at the side, and that's the head of the bat. So different kind of names given to exactly the same kind of thing. No, it's not going to rub out. Let's try and clear this. Uh, Now, it's also important that, like I said, an absent corpus callosum may be associated with mild ventriculomegaly. It might be associated with an absence of the cavum septum pellucidum. So basically, you don't have a cavum in the center. You have one communicating ventricle in the center. And it's really important if you have this appearance that you're really looking at the the corpus callosum quite carefully in its entirety because it may be associated with an absent cavum septum pellucidum. Again, just another classical example. This is basically partial dysgenesis with colpocephaly. You can see a small element of the corpus callosum here anteriorly, but nothing that goes here. Very difficult to see it at the back, and complete splaying of the ventricles with colpocephaly. Occipital horns are dilated. Now, it's quite interesting that when you follow these scans up, and even if followed up with MRI, you find that the ventriculomegaly itself does not progress in the majority of cases who are asymptomatic. It's only when there is an association with posterior fossa abnormalities that you feel a little bit more anxious about the risk of developing possible dilatation of the ventricles of an obstructive cause. Now, why do the ventricles get displaced? And the reason for that is basically when you don't have a connection between the two hemispheres, there's a large amount of neural tissue over here which is absent, which supports these ventricles and keeps them together. So when it's absent, there's nothing to keep the ventricles together and they get widely splayed. But more importantly, because they're getting stretched, and naturally, because they communicate with the third ventricle and the aqueduct basically get pulled up. And this is why we call it the Viking head appearance. I'm not sure that it really bears out. A very important aspect of looking at it is trying to demonstrate the pericolossal artery. And really, this is the entire course of the pericolossal artery. Here you've got complete absence of the corpus callosum, so you can't see it. You can see these vessels over here, which basically branches of the middle cerebral artery, thalamostriate vessels that are going in. But actually, demonstration of the anterior cerebral is not there. And basically, these pericolossal arteries that take their origin from it, completely absent. I would always do it. And the reason I would always do it is this is a really nice example, again, where the pericolossal artery basically does not go back in entirety. Now, what you have is the anterior part of the corpus callosum that's visible, but you do not have the posterior part of the pericolossal artery. So actually, there is posterior agenesis in this particular zone over here. Over here, again, you have the anterior part of the corpus callosum developed, but there's absolutely nothing posteriorly. So it's a really good way to be able to demonstrate it. Similarly, I mean, if you look at this particular baby over here, really, this is an in utero scan, but the anterior part of the corpus callosum has not developed. And again, similar on the right lower, you've got the anterior part to the anterior commissure that's developed. You can see the tram tracks, but actually when you try to trace the posterior part, it's not visible at all. So from your perspective, you can see that the pericolossal artery is not visible. This is the inferior cerebral vein. So a really good way of kind of making a determination in situations like this is tracing your pericolossal artery and basically making sure that you've confirmed and that you've preferably confirmed in more than one plane. Similar image, sunburst appearance. This is what we call as corpus callosum dysgenesis. So you have the anterior part over here, and then the posterior part is not formed. So you have that classical sunburst appearance with widely splayed lateral ventricles. Again, just a similar example of how this used to look like on a Fujitsu scan. This is, again, an element of the anterior part that's there, but not the posterior part. It's here that I would really want to put my Dopplers to demonstrate the pericolossal artery from the anterior cerebral and have a look at things. And then really what you might find is the occasional case which is associated with more widespread abnormality where there is significant dilatation, even midline shift. This is quite severe. And these are ones where I'd be a little bit more cautious. Again, this is not isolated. This is a little bit more dilated. Look at the baby closely. I mean, this is the kind of situation where I would definitely be getting an MRI done. Would I routinely MRI all these babies? No. What is practice like where you work at the moment, guys? Are you MRIing all your babies with an absent corpus callosum?
Yes, we are actually. Every
Yes, we
baby
are
with,
also doing.
yeah, yeah.
Okay, fair point. I think, enough there to kind of say that you want to make sure that you're not missing anything. Our big challenge over here is insurance. And hence they'll all get followed up. but routine MRIs for all of them becomes very difficult in our part of the world. Oh, Maria, what are you guys doing? Maria, you
Yeah,
told
I
me.
was going to, yeah,
Yeah.
I was going to ask you actually because we would do the MRI. We have a very low threshold for MRI sometimes, so we would do an MRI for sure for a complete absence.
Yeah.
Um, some of us would also do for the thinning of the corpus callosum. That's when I was wondering when what would be reasonable when you have an abnormalities which is isolated
It's
and the baby looks normal but it's just a neonate.
so it's very difficult question to answer again because we know that a significant proportion of the population may have partial agenesis and live completely normal lives. All the same, what I'd say is that there is also increasing recognition that absence of the corpus callosum. See, studies that showed that there were no genetic associations, and with MRI becoming more widespread and easily available, I think there is a lower threshold for wanting to know the brain structure. And in particular, if the brain structure has an abnormality over there, then being able to counsel those parents early intervention, because there is an element of developmental delay. So I'm just giving you some of the literature. This article is part of the article library. It's basically from an article from 2023 by published by colleagues, I think, from the Middle East. And what they basically show is that isolated no other abnormalities associated with 66% children have a normal outcome, but the remaining have developmental delay difficulties in cognitive analysis and complex reasoning. Now, depending on society, there are parents who would want to know this, who might want to take extra precautions. We also know that there are risks of having other abnormalities in the brain itself. So it's a really difficult area. And I think, at least in the majority of cases, certain modern societies where MRI is easily available, not expensive, I think you'd have a lower threshold for wanting to do it. I think for partial agenesis, completely normal baby, nothing else wrong with him, I think my practice would be to definitely follow them up, very low threshold for kind of developmental assessment. And any abnormalities, you can do an MRI at a later date as well. But I think if you had complete agenesis of the corpus callosum and the parents could afford it, I'd be getting an MRI done. If there's an element of colpocephaly there, no doubt about it. So it's really dependent on whether the parents can afford it or not. That would be my approach. Now, like I said, when there's an underlying genetic and cortical problem, the prognosis becomes much worse and it's really guarded. Now, associated with the absence of the corpus callosum, you can have absence of the cavum septum pellucidum, and it classically presents with ventricles that basically communicate with each other in the midline. Because the cavum septum pellucidum, which is basically a very thin, fluid-filled membrane that basically separates these two ventricles, which is present early on. So normally what happens is uh, you might have the cavum septum pellucidum early in the developmental time. And with time, really, as the brain gets more mature, what you find is the cavum septum pellucidum may completely disappear, and you're just left with the lateral ventricles communicating through the foramen of Monro with the third ventricle and the fourth ventricle. But in some cases, it may be that the cavum septum pellucidum is absent from birth, and it counts as a midline defect. And again, this is a group of babies where I have a much lower threshold of thinking very strongly about looking for other midline defects and thinking of conditions like septoptic dysplasia. If you have a very smooth appearance to the brain, as you can see over here, you can see virtually no sulcal gyral maturation, then really thinking about the possibility that this might be a neuronal migration disorder, that this might be a holoprosencephaly. Uh, these are kind of babies where I'd have a lower threshold for getting an MRI done. And then you have some developmental variants, like the cavum vergi. So the cavum vergi is a normal developmental variant seen in preterm babies. And really what it means is, from our perspective, sorry, I'm just having a little bit of a problem with my marker, is that Anteriorly, the cavum septum pellucidum in the midline kind of sagittal view communicates with this area at the back, which is called the cavum vergi. And with time, what happens is the cavum vergi gradually gets absorbed, the point where the cavum septum pellucidum gets absorbed, and you just have lateral ventricles, which are basically communicating with each other through the foramen of Monro, through the third ventricle and the fourth ventricle. So eventually, these structures will gradually disappear with time. The persistence of the cavum vergi or the cavum septum pellucidum in isolation are not things that are considered abnormal unless the baby has other soft markers. And really, from our perspective, a third structure, which is called the cavum velum interpositum, which is seen over here, again, is another developmental variant that usually disappears. But if it's present in itself, it's just like a prepontine cyst that you see over here. Small area which is fluid filled, which should have no significant developmental kind of effects on the baby. I'm going to basically probably leave this today because I think we can cover posterior fossa anomalies in a lot more detail with the next session. But because counseling here has a significant proportion of problems. But what I'm going to say is that just persistence of the cavum vergi and the cavum velum interpositum in themselves have got no significance if obviously there's nothing else that's wrong with the brain. But if you have an absent cavum septum pellucidum, I think these are babies, I mean, who should have an MRI. For an absent corpus callosum, partial, isolated, small, thin, very difficult. Parents can afford. Will you get an MRI? Will you not? I don't have the right answer. I think if you have easy proximity and the parents can afford and you're getting one done, I don't think you're wrong. But what is important is that isolated without any abnormalities, you know, two-thirds of these babies, these children, have a normal outcome, and the remaining don't have significant problems unless you have other problems associated with it. Look at your scan images. You know, a simple absence of the corpus callosum, like if you see just anterior absences, you can see over here with the rest of it present, with no other abnormalities, with a completely normal head scan, then really, again, you know, developmental follow-up may be sufficient in these cases. Again, posterior dysgenesis, uh, you have to be a little bit more careful if it's associated with posterior fossa abnormalities. And just be aware that some babies will develop and get thinning of the corpus callosum because of white matter injury. When it's graded, and I will be showing you some images of what severe white matter injury looks like. I mean, the corpus callosum can be destroyed to the point where it's thin, where the anterior or posterior parts are absent. And really, that's a reflection of white matter injury. Now, I can tell you for a fact that not all centers have the ability to be able to do term MRIs at 40 to 44 weeks for every preterm baby that leaves the unit because of cost, because of expense, but also because from our perspective, if you have a good, well-developed neurodevelopmental follow-up program, it's probably better to have that baby followed up if the parents can't afford it than to have them pay for a very expensive, I would say, scan in the right centers, like if you go to Linda DeVries Center or if you go to Mary Rutherford in London, they will get MRIs done for all their preterm babies, I think, at 40 to 44 weeks. And they have the skill as well as the abilities to be able to kind of, I would say, counsel parents based on it simply because of their expertise in this area. Again, the ability for every neuroradiologist to report these scans and accurately prognosticate is a very important aspect of it. There's work that's been done by Laura Ment that actually shows that the correlation between preterm MRIs done at term and certainty of an abnormal neurodevelopmental outcome is not great. But just an awareness that the corpus callosum damage can be acquired as well. It may not be congenital. So any questions? Because we're about 8:32 and I want to finish. Any questions? Okay. So what I'd like everyone to do is, for those of you who are populating your logbooks, I am currently doing sign-offs. So at least two of you have now stepped up to L3. One of you is on way to kind of L4 based on what they've shown me so far. They don't need to have 50 scans. They can scan. I think, again, just for those of you who are not maintaining a log, at least try to do it locally if you can. And if you want to, there's still the opportunity for you to anonymously have one-on-ones. I'm going to do one-on-ones with some of you. Maria, book a session with you, and then Dr. Babin Seva. But if any of you want one-on-ones, this is a relatively free period. I've just finished 2 weeks of service. I'm quite happy to accommodate that. So God bless you all, and thank you for your patience.
Thank you.
So
Thank